Hello students, my name is Dr. Arpit Agarwal and today we will be discussing the subject wise questions of pharmacology. So let's begin with the question number 1. Question number 1 says that all of the following effects are produced by inhibitors of prostaglandin synthesis except. The answer would be option number B, that is prolongation of prothrombin time. So prostaglandin synthesis inhibition, that is done by non-steroidal anti-inflammatory drugs. NSAIDs is what we call them. They inhibit the enzyme cyclooxygenase. Cyclooxygenase inhibition, the hash sign being used for inhibition or antagonism. So by inhibiting the COX enzyme, NSAIDs inhibit prostaglandin synthesis. What are the actions that result? Number 1, anti-platelet action. Anti-platelet action is due to inhibition of thromboxane A2 synthesis in platelets. It's very important to emphasize that synthesis of thromboxane A2 is inhibited, but the enzyme that is inhibited would remain as COX, and this action we seen typically and only with aspirin. One of the irreversible inhibitor of COX, aspirin inhibits thromboxane synthesis, not the thromboxane synthase. Thromboxane synthesis inhibits, aspirin antiplatelet effect. Second, gastric erosion. Prostaglandins have what we call as a gastroprotective nature. Prostaglandins are gastroprotective. They protect the gastric mucosa by increasing the secretion of mucus in stomach and also increasing the blood flow to gastric mucosa. So prostaglandins are gastroprotective. Inhibition of prostaglandins results in gastric erosion caused by NSAIDs. And third would be prolongation of uterine contraction or labor. Because please remember, prostaglandins stimulate uterine contraction. So all these actions are caused by inhibition of prostaglandin synthesis. Fourth option, that is option number B, increase in prothrombin time. This action will be caused by drugs that inhibit coagulation pathway. And particularly affecting factor number 7. Factor 7, like warfarin. So prothrombin time has got nothing to do with prostaglandins. It is inhibited or increased or affected by drugs that affect coagulation factors like warfarin. So option number B is the answer to question number 1. Moving on to second questions. Drugs that have been found to be useful in compensated heart failure include all of the following except. It's a very, very important question and students have difficulty in answering this kind of question. The option will be, correct option will be option number C, that is beta receptor agonist. Question number 2, the correct answer will be option number C. So we have two kinds of congestive heart failure that can be compensated and congestive heart failure which is decompensated, also known as acute CHF. What kind of drugs will be useful in the treatment of these two kinds of congestive heart failure? Remember, in congestive heart failure which is compensated, symptomatic treatment will be provided by diuretics, and so will be the case in decompensated. Diuretics will be given in both the cases. Only difference is here diuretics will be given as oral, and here mostly we will use the intravenous form of diuretics. Secondly, vasodilators. Again, drugs will be given orally. Here also vasodilators will be used, but they will be intravenously given. So in oral vasodilators, what comes to our mind or should come to our mind is very, very important: ACE inhibitors or angiotensin receptor blockers, both given orally. We can also give calcium channel blockers, but they are not so commonly used. Please remember, calcium channel blockers are not very commonly used. We can also use a combination of hydralazine plus isosorbide. This combination is also being used nowadays for treatment of congestive heart failure, which requires oral treatment. If we talk about vasodilators which are given intravenously, that is in decompensated, then what comes to our mind is 3N. 3 N's would come to our mind, and they would be composed of nesiritide, which is a recombinant BNP, recombinant form of brain-derived natriuretic peptide. What should also comes to our mind is nitroglycerin, IV nitroglycerin, and the third, nitroprusside. So 3N, as I have indicated, all are intravenously given vasodilators in acute or decompensated heart failure. While in compensated, vasodilators which are used are predominantly orally in the form of ACE inhibitors, calcium channel blockers rarely, and sometimes hydralazine plus isosorbide dinitrate. If CHF remains uncontrolled despite these two therapies, then other therapies are added to these ongoing in both the cases. The third drug that can be added would be beta blockers, again given orally in cases of compensated, and here we would give beta agonist. Beta agonist, they will be given intravenously. Now, which beta agonist are going to be used? Very, very important, dopamine. You all know dopamine is a catecholamine, cannot be given orally, only used intravenously. Dobutamine, and third, I hope you all are recollecting, noradrenaline. So these three beta agonists are given intravenously in the treatment of decompensated or acute CHF, while beta blockers, you all know there are many kinds of beta blockers, they are given orally in cases of compensated heart failure. So that is the answer to this particular question. Beta agonists are used in treatment of acute or decompensated heart failure, while beta blockers are used in the treatment of stable or compensated heart failure. There are some new drugs also, but one drug must be mentioned here, that is digoxin. Digoxin is a drug which can be given both in the cases of compensated and decompensated heart failure. Compensated, decompensated, in both cases digoxin can be given. Finally, to wrap up, new drugs. In compensated, one must remember a very important new drug of sacubitril. Sacubitril, recently asked, it's a neprilysin inhibitor. Sacubitril is an oral drug given for the treatment of compensated CHF, and here in the new drugs category, ND is new drug, one must remember a drug known as levosimendan. Levosimendan, I hope you have heard of the name levosimendan. It is a calcium sensitizer, again given intravenously for the treatment of decompensated heart failure. And please remember to wrap up this question by mentioning phosphodiesterase type 3 inhibitors. Phosphodiesterase type 3 inhibitor like amrinone, which are again intravenously given and therefore used only in decompensated or acute CHF. So to wrap up this question, treatment of compensated and decompensated heart failure is very different. Although some of the classes of drugs remain the same, but the essence to remember is that in treatment of compensated heart failure, drugs will be given orally because patient is having stable symptoms and we treat this on an OPD basis, while in decompensated, intravenously given drugs will be used because the patient is very sick and mostly he is admitted. So diuretics relieve the symptom in both the cases, but oral versus IV, furosemide oral versus furosemide intravenous. Vasodilators are used in both the cases, but again there is difference of the drugs which are used, oral versus intravenous. So ACE inhibitors are very important class of drugs used in normal or stable CHF, while 3N, as you can see, are the vasodilators preferred for decompensated. Beta blockers are the drugs which are started in compensated if the symptoms cannot be controlled by ACE inhibitors and diuretics, while beta agonist, beta 1 agonists like dopamine, dobutamine and noradrenaline given intravenously for short term to tide over the crisis are drugs which are used to provide support to heart in cases of decompensated or acute CHF. Rest we have the new drugs in which sacubitril is very important and so is levosimendan. So very important question based on concept. Moving on, question number 3. Question number 3 again from CVS. It says a patient of atrial fibrillation is on digoxin therapy. So please remember atrial fibrillation, which is an arrhythmia, is also one of the indication of using digoxin. Sometimes students think that digoxin is only used for CHF, but it is also useful in cases of atrial fibrillation. So patient of atrial fibrillation is on digoxin therapy. Which of the following responses do you expect? Restoration of normal sinus rhythm, conversion of atrial fibrillation to atrial flutter, increase in atrial fibrillation frequency but decrease in ventricular rate, decrease in atrial fibrillation frequency but increase in ventricular rate. The correct answer to question number 3 would be option number C. Again question number 3, based on concepts, the correct answer is option number C. What is atrial fibrillation and what is the treatment and how does digoxin act in atrial fibrillation? So in atrial fibrillation, atria, so our atrial tissue is contracting at very high rates. So it is having 300 to 500 beats per minute. So there is ectopic generation of impulse in atria and therefore the atrial rate is very, very high. Now these impulses are passed through AV node to ventricles. Now all the impulses do not pass but most of them pass. So let's say ventricular rate is also very, very high. Suppose ventricular rate is around 200 beats per minute. This is the situation that due to ectopic impulse in atria, a lot of impulses are passed to ventricle and therefore ventricular rate is very, very high. At such high ventricular rates, ventricle do not get enough time to relax. When ventricles do not get enough time to relax, their filling is impaired and therefore it results in reduced cardiac output. That is the cause of symptom in atrial fibrillation. Now what are the aims of treatment? How do we treat atrial fibrillation? Number 1 is called rate control, and the second aim will be called as rhythm control. See, as the name suggests, rate control. The purpose of this particular aim is to control ventricular rate. Control ventricular rate, decrease the ventricular rate so that ventricle get enough time to fill, to relax, and therefore ventricular output or cardiac output will increase. So that is the first aim in atrial fibrillation, to bring the ventricular rate under control. In order to bring ventricular rate under control, what you need AV blocking drugs. You need those drugs that will block conduction at AV node. So if AV node is blocked or made more refractory, the conduction from atria to ventricle will decrease and ventricular rate will come under control. Now I hope you can recollect some of the important AV blocking drugs that block conduction via AV node. The first and the foremost example is beta blockers. Beta blockers block conduction via AV node, and so do a drug called verapamil. Beta blockers or verapamil can be given immediately, beta blockers being the preferred drug to bring ventricular rate under control. Coming to digoxin. Now digoxin has some important properties in the same regard. The digoxin can also block AV node conduction. How it does? What we say, it has a vagomimetic effect. Vagomimetic effect. So if you'll recall from the knowledge of autonomic nervous system, vagus tends to decrease heart rate by blocking the conduction at AV node. What it does, it increases the refractory period of AV node. So that is what we call as a vagomimetic effect, to increase the refractory period of AV node, and that is also what digoxin does to AV node. So it will make the AV node more refractory, and therefore number of impulse passing to its ventricle will decrease. So that is how ventricular rate will come under control, and that is why we see that option number C, decrease in ventricular rate, is the correct option here. If we talk of rhythm control, then it would depend whether the patient is hemodynamically stable or not stable. So it depends on the BP of the patient, if the BP of the patient is maintained or not maintained. If the patient is hemodynamically stable, then we give class 3 or sometimes class 1A antiarrhythmic drugs like amiodarone, dobutalide, or even Curide. If the patient is hemodynamically unstable, his BP is falling, then cardioversion. Cardioversion is the thing to perform to bring rhythm under control, that is to convert AF back into sinus rhythm. That is the meaning of rhythm control, to terminate AF and re-establish the sinus rhythm, that is rhythm control. So two aims to atrial fibrillation treatment. The preferred aim is to control ventricular rate so that ventricle get enough time to relax and thereby increasing cardiac output. So we use drugs that increase the refractory period of AV node or the drugs that block AV node. Beta blockers, calcium channel blockers like verapamil, and also digoxin. Digoxin by having vagomimetic effect. The second aim, once the rate comes under control, is rhythm control, that is to convert AF back into sinus rhythm, and for this class 3 or class 1A antiarrhythmic drugs are used. Cardioversion is used if the patient is hemodynamically unstable. So very important question, frequently asked topic, atrial fibrillation, its treatment, both important in medicine as well as in pharmacology. Question number 4, all of the following indications of vasopressin are based on stimulation of V2 receptor except. Please, in pre-PG examination, read the question carefully and always be careful about except. So that is an important thing to remember. The answer to this particular question would be option number D, esophageal varices. So let's look at question number 4. Question number 4, the correct answer is option number D, esophageal varices. So if we look at vasopressin or ADH, the other name, vasopressin or ADH, and its receptors. So basically there are two kinds of receptors, V1 and V2. Now V1 is further subdivided into two types known as V1A and V1B. Some of the books also called this V1B as V3. So we can say that there are three kinds of vasopressin receptors in our body, V1A, V1B and V2. Okay, V1b also known as V3 in some of the books. V1a receptor is mostly present on blood vessels and this causes vasoconstriction. That is why the name vasopressin. So ADH is also known as vasopressin because it can cause vasoconstriction, and this is done by the receptors known as V1a. V1b are present in CNS, and in CNS they are present mostly in anterior pituitary. And what do they cause? They cause release of ACTH. Release of ACTH can be caused by V3 or V1b receptor. We do not know what is the physiological importance of this particular action. Coming to V2 receptors, very simple to remember. We have got in human body 2 kidneys and therefore V type 2 receptors in kidney. So please remember 2 kidneys that everybody knows, and therefore V type 2 receptor. This will be present in mostly collecting ducts. And which part of collecting duct? It will be present more in medullary part of collecting duct greater than the cortical part of collecting duct. Again an important question which is asked very frequently. So V2 receptors are present on collecting ducts, mostly in medullary part of collecting duct, and what do they cause? They cause increased water reabsorption. Increase in water reabsorption is the function of V2 receptors. That is their first location. And second location, they are also present on endothelial cells. And by the presence on endothelial cells, what do they cause? I hope you are remembering, they cause release of von Willebrand factor and factor 8 from endothelium. Von Willebrand factor and factor 8. So these are the actions depending on the receptors of vasopressin in our body. Now if we look at these actions, then stimulation of V2 receptor is useful in 2 conditions. Number 1, central diabetes insipidus or simply diabetes insipidus. Condition where ADH secretion from pituitary is low, we give this drug and it acts on V2 receptor, vasopressin or desmopressin, and it helps in water reabsorption. So this is useful for diabetes insipidus or the central type of diabetes insipidus as it's sometimes known. The action on endothelial cells is useful for von Willebrand factor disease, also for hemophilia. Action on V1 type A receptor is used for constriction of blood vessels, and that is used for treatment of bleeding esophageal varices. So as you can see, the question is asking which action is not due to V2 receptor. All actions are due to V2 except. So this action, V1A action, vasopressin action, useful in treatment of bleeding esophageal varices, is V1 type A receptor action, and that is why this is the answer to question number 4. Question number 5. Which of the following agent is useful for the oral treatment of both pituitary as well as renal diabetes insipidus? So again a question using the knowledge of vasopressin, used for oral treatment of both central as well as renal diabetes, that is nephrogenic diabetes insipidus. The answer would be option number B, hydrochlorothiazide. So question number 5, correct answer is option number B. Now let's look at diabetes insipidus. There are 2 types of diabetes insipidus that are known. First type is known as central diabetes insipidus, and the other type will be known as nephrogenic diabetes insipidus. These are the 2 types of diabetes insipidus. What happens in central diabetes insipidus? ADH secretion is decreased. The secretion of ADH occurs from pituitary, and pituitary is a CNS part, so that is why this type of diabetes insipidus is known as central, because the disease is originating inside CNS in pituitary. So secretion of ADH from pituitary is low. That is the problem in central diabetes insipidus. Now since ADH is not being secreted, the simple solution is we give ADH from outside in the form of desmopressin. Desmopressin. So desmopressin is the treatment of choice of central diabetes insipidus sorry, or simply called diabetes insipidus. This can be given as subcutaneous route, nasal spray, or oral tablet. Whatever route is used, desmopressin is the drug of choice. Sorry. What happens in nephrogenic diabetes insipidus? That ADH secretion is normal. There is no problem in pituitary and there is no problem in secretion of ADH from pituitary. Then what is the cause? Cause is that collecting duct cells become insensitive to ADH. So insensitivity to ADH is the cause of nephrogenic diabetes insipidus. So ADH is released from pituitary via blood, reaches kidney, but is unable to exert its action because collecting ducts are insensitive to ADH. That is the pathology in nephrogenic diabetes insipidus. So what will be the treatment? First of all, the drug that comes to our mind is that can we use desmopressin? But you see ADH level is already normal, so desmopressin has absolutely no role in the treatment of nephrogenic diabetes insipidus. This is a very frequently asked option. So you have to be very, very clear. Then since desmopressin cannot be used, then which drug is employed? Thiazide. Thiazides are drug of choice for treatment of nephrogenic diabetes insipidus, and please remember in this condition they will exert a paradoxical antidiuretic action. Thiazides will exert a paradoxical antidiuretic action, something that we have not been able to explain clearly so far. That action is exerted and thiazides are considered drug of choice for treatment of nephrogenic diabetes insipidus. Now the question is asking for both central as well as nephrogenic, which drug would be useful, and the answer is again thiazide. So thiazides can be used in both, although they are not drug of choice for central, but they still can be used to treat central. So if the question asks which is the preferred drug to treat both kinds of diabetes insipidus, then the answer without any doubt is thiazide. The only question that remains in this topic is that sometimes lithium, a drug used for bipolar disorder, lithium can also cause nephrogenic diabetes insipidus. So lithium induced nephrogenic diabetes insipidus. What will be the drug of choice? Because please remember, thiazides and lithium cannot be given together. Thiazides will cause lithium toxicity. So thiazides are contraindicated with lithium. So there is a patient who is having bipolar disorder, receiving lithium, and lithium causes a side effect of nephrogenic diabetes insipidus. You want to give thiazide, but thiazides are contraindicated with lithium. So what is the drug of choice? I hope all of you remember amiloride. Amiloride is the drug to treat nephrogenic diabetes insipidus induced by lithium. Otherwise, for nephrogenic diabetes insipidus, thiazides are considered drug of choice. So these two questions, question number 4 and question number 5, summarize what you need to know about ADH and its physiology. So we have discussed ADH receptors, their location and their action. We have discussed the deficiency of ADH, whether actual or functional, and we have discussed their treatment, and we have discussed the topics which are somehow related to this particular diabetes insipidus problem. Moving further, question number 6. The question now shifts attention to skeletal muscle relaxants, and the question asks the most rapidly acting non-depolarizing neuromuscular blocking agent which can be used as an alternative to succinylcholine for tracheal intubation is. The answer will be option number A, rocuronium. Question number 6, correct answer is option number A, rocuronium. So we have muscle relaxants again of two types. Muscle relaxants are of two types. One is called depolarizing muscle relaxants and the other one is called non-depolarizing. Non-depolarizing muscle relaxant. Depolarized muscle relaxants are characterized by only one molecule, succinylcholine. So succinylcholine is the only available depolarizing muscle relaxant. Now succinylcholine has a very rapid hydrolysis, because you see, as the name indicates, it is related or a substance which is similar to acetylcholine. So succinylcholine and acetylcholine both are esters of choline. So you know that there are many esterases present in plasma and we call them pseudo choline esterases which are present in plasma. They cause hydrolysis of succinylcholine and therefore it goes rapid hydrolysis, so it has a very short T-half and only of 2 minutes. So it's the shortest acting muscle relaxant, very short T-half due to rapid hydrolysis by pseudocholine esterases in plasma. So what is the use? Use is only intubation. Tracheal intubation to relax the muscles of larynx and facilitate endotracheal intubation is the only important use of succinylcholine. But suppose due to any contraindication, if a patient cannot be given succinylcholine, then what are the alternatives? So the alternatives that are present in the other category of non-depolarizing muscle relaxants should be also very short acting. That is the requirement, short and very quick acting, so that they can also be used as a substitute for succinylcholine, and the answer is rocuronium. If rocuronium is not given in the options, then you are going to look for vacuronium. So rocuronium is the preferred non-depolarizing muscle relaxant that can be used as a substitute of succinylcholine. If somehow in any of the question this is not given, then you can look for another quick and short acting non-depolarizing muscle relaxant, that is vacuronium, but only if rocuronium is not given. So rocuronium is the answer to question number 6. Moving ahead with question number 7, one of the following statement about succinylcholine is true. So all are false except, or which one is true? It may induce life-threatening hyperkalemia. It seems true. It has a long duration of action. Just because of knowledge of previous question, we know it has a very short duration of action, so this is not true. It is drug of choice in non-traumatic rhabdomyolysis. This is also false. It can cause hyperkalemia, and muscle damage will worsen hyperkalemia, so this is not to be used in patients with muscle injury. And it is used in patients with spinal cord injuries with paraplegia. This is also wrong. Again, with spinal cord or nerve injuries, there is a risk of hyperkalemia. So the answer will be option number A. It may induce life-threatening hyperkalemia. So question number 7, the answer is option number A. So staying with succinylcholine, and succinylcholine side effects leading to some contraindications. So what are the possible side effects and what are the contraindications based on those side effects with succinylcholine? Succinylcholine has most important problem of causing too much hyperkalemia. Too much hyperkalemia. And too much hyperkalemia may lead to even fatal arrhythmias. So that is always a problem with succinylcholine. It causes hyperkalemia and which may even cause fatal arrhythmia sometimes. Now what are the increased risk factors for developing hyperkalemia and therefore subsequent arrhythmias? So please remember, any patient with muscle injury. Now in muscle injury, you may recall terms like rhabdomyolysis. Please recall crushing injuries. Please be mindful of trauma. So anywhere where you suspect muscle injury, muscle damage, the potassium stored in muscle will come out and will contribute to hyperkalemia caused by succinylcholine. So avoid succinylcholine in any of these cases. Second, patients with increased risk occurs in patients with burns. There is increased risk of hyperkalemia in children. There is increased risk of hyperkalemia in nerve damage. So these are the conditions where risk of hyperkalemia and therefore subsequent arrhythmia with succinylcholine is high. So succinylcholine should be avoided in patients who present with muscle injuries, patients who present with burn. Children are at high risk of developing arrhythmia, so try to avoid, and patients presenting with nerve damage also should be avoided with treatment of succinylcholine because of the problem of hyperkalemia, which may lead to even sometimes fatal arrhythmias. So that is why only option number A is true in question number 7. Question number 8, an old woman is required to have 4 cycles of cancer chemotherapy. After her first cycle, she developed chemotherapy-induced thrombocytopenia. In the next cycle, it would be appropriate to give this patient. So question is very simple. It is a fact-based question. What are the drugs for thrombocytopenia, especially induced by cancer chemotherapy? Answer would be option number D, oprelvacin. Question number 8, the correct answer is option number D. The question is asking treatment of thrombocytopenia, particularly that induced by cancer chemotherapy. First drug that is used is recombinant form of interleukin 11. Recombinant form of interleukin 11, that is known as oprelvacin. Oprelvacin. What it does, it simply stimulates thrombopoiesis. So oprelvacin, it's a recombinant form of interleukin 11 and it will stimulate thrombopoiesis. So this is used for treatment of chemotherapy-induced thrombocytopenia, and that is what question is asking. So answer will be oprelvacin, treatment of chemotherapy-induced thrombocytopenia. It will stimulate thrombopoiesis. Moving further, there are some new drugs which also should be known, and one drug is romiflostim. Now you see, we want to stimulate thrombopoiesis. So stimulation should remind us of a word, stim. So the name of the drug is acting in stim, that means it is a stimulator. What do we want to stimulate? We want to stimulate platelets. So the spelling is PLO, but for the simplification, if you remember PLA, romiplastim for simplification, then we can simply see that it is a stimulator of thrombopoiesis, stimulator of platelet. So romiplastim is another drug which stimulates thrombopoiesis. Third drug is also simple. We are saying stimulate thrombopoiesis. So thrombo to stimulate or to mean thrombopoiesis. Polyethylene glycol is added, that means PEG, and a prefix is added as L. So L-thrombopeg. L-thrombopeg is another drug that will stimulate thrombopoiesis. So these three drugs, oprelvecin, romiplastim, PLO is the correct spelling, romiplastim, and L-thrombopeg. Again, the correct spelling here is without H. So the correct spelling is thrombo, but I think a mere addition of H would not cause much of difference. So we can help us in remembering L-thrombopeg by writing L-thrombopeg. So romiplastim and L-thrombopeg, these two drugs are used for treatment of idiopathic thrombocytopenic purpura, ITP, while oprelvecin, as written above, is used to treat chemotherapy induced thrombocytopenia. So these are three drugs which increase platelet count or stimulate thrombopoiesis. The first one is used to treat thrombocytopenia secondary to cancer therapy, and the last two, romiplastim and L-thrombopeg, are used to treat ITP. The last thing to remember, out of these three drugs, L-thrombopeg is the only oral drug. So L-thrombopeg is oral, while the other two, first and second, are injectable drugs. So this is about question number 8. Moving on to question number 9, with respect to ticlopidine, clopidogrel. So the question is asking what is the difference in clopidogrel as compared to ticlopidine. Is more likely to cause formation of antiplatelet antibodies? This is wrong. Less likely to cause neutropenia? This is correct. So answer is option number B. More likely to cause severe bleeding? Nothing of this sort. And has a greater antiplatelet effect? That is also not true. So option number B is the correct answer to question number 9. Option number B. What are we discussing in this chapter? What are the likely questions which can be asked from this topic? So we are discussing ADP. ADP, receptor antagonist. ADP receptor antagonist are antiplatelet drugs. So ADP receptor antagonist is the topic that is very, very important, and every year we see at least one question coming from this topic of antiplatelet and particularly ADP receptor antagonist. So first thing should be known, which receptor of ADP are blocked, that is P2Y12 receptors of ADP. P2Y12 receptor of ADP, they are present on platelet, and this is the receptor being blocked. This is the receptor being blocked. Three drugs are important in this category. Number 1, the first drug which came was ticlopidine. Ticlopidine was the first molecule in this category, and this drug had a very important side effect of bone marrow suppression. Bone marrow suppression, particularly neutropenia and thrombocytopenia. So there was too much suppression of bone marrow resulting in thrombocytopenia and neutropenia. So this drug is not used nowadays, or we can say this is not popular because of this side effect. Subsequent to ticlopidine, another drug was developed known as clopidogrel. Clopidogrel was the next member of ADP receptor antagonist. Clopidogrel had one advantage over ticlopidine, that it was causing no bone marrow suppression. Bone marrow suppression was not seen with clopidogrel, and that is the answer to the question being asked, that as compared to ticlopidine, clopidogrel has minimal bone marrow suppression or thrombocytopenia or neutropenia. But there occurred a couple of different kind of problems with clopidogrel. What were those problems? Number one, issues that occurred with clopidogrel. Number one, it had a slower onset, and secondly, I hope you can recollect, it need CYP 2C19, very important, CYP 2C19 for activation. So this enzyme, cytochrome 2C19, 2C19 present in liver is required for clopidogrel because this is a prodrug. This is a prodrug, so this is required for activation of clopidogrel, and this enzyme can be inhibited by proton pump inhibitors like omeprazole. So when you give clopidogrel with any of the proton pump inhibitor like omeprazole, it is not activated, and therefore there occurs failure of clopidogrel therapy. So there were two issues seen with clopidogrel: slower onset of action and the metabolism issue that is requiring 2C19, and therefore interaction with proton pump inhibitor. What was the solution to these problems of clopidogrel? In the form of a newer drug known as prasugrel. Prasugrel is the latest member of this family, ADP receptor antagonist. Prasugrel, number one, had a quicker onset, quick onset, so that slower onset problem was taken care of, and secondly, it has no need of CYP 2C19. So both the disadvantages of clopidogrel were over with the introduction of prasugrel, which had a quicker onset and also did not require CYP 2C19 in liver. So there was no interaction with proton pump inhibitor, it was safe to give with them, and there were less drug interactions in general. But prasugrel came up with its own problem, that is increased risk of bleeding. Increased risk of bleeding as compared to clopidogrel is seen, and therefore this drug is contraindicated if the patient is having history of stroke. So that is again a very important point, why prasugrel is still not as popular as clopidogrel, because although it has a quicker onset and no need of CYP 2C19, but it causes increased risk of bleeding and therefore contraindicated if the patient is having history of stroke. So that is why prasugrel is not still as popular as clopidogrel. So what I have done, I have tried to explain to you this class as a whole. P2 Y12 receptor antagonist of ADP used as antiplatelet, ticlopidine followed by clopidogrel and followed by prasugrel. The question is asking difference in first and second, but it is very common for MCQs to ask difference in second and third as well. So the entire topic should be pretty clear to a serious pre-PG aspirant. Moving on to question number 10. Which one of the following statements about doxycycline is false? So we leave hematology and we come to antimicrobials, particularly protein synthesis inhibitor doxycycline. It is bacteriostatic. This is correct. I hope all of you know that most protein synthesis inhibitor are bacteriostatic, including doxycycline. It is excreted mainly in feces. Very important point. Most of the tetracyclines are excreted in urine except doxycycline. So doxycycline is excreted in bile and bile goes to feces, so this is also correct. Option number D, it is used in Lyme's disease. It is the drug of choice for Lyme's disease, so option number D is also correct. The correct answer here is, the statement which is false is option number C. It is more active than tetracycline against H. pylori. That is a false statement to make. So question number 10, the correct answer is option number C. Option number C is the correct answer. It is a false statement. So doxycycline. Doxycycline, number 1, it is a bacteriostatic drug. Bacteriostatic, it binds to 30S. All tetracycline binds to 30S and it inhibits attachment of tRNA at A site. So it's a protein synthesis inhibitor, in short, protein synthesis inhibitor, and most protein synthesis inhibitors are bacteriostatic. The important point here to remember is binding is to 30S subunit of ribosome, not 50S. Second point, tetracyclines. Tetracyclines as a rule are having renal excretion. Renal excretion, and therefore they are not considered safe. They are not safe in patients with renal failure. In general, tetracyclines are not safe, but there are couple of exceptions to this particular rule. And what are those exceptions? There is doxycycline, and there is a new drug known as tigacycline. Tigacycline is a glycosides, a newer derivative of tetracyclines. Both these drugs, doxy and tigacycline, they are excreted in bile. They are having bile elimination. So these are the two molecules of tetracycline class which are safe in renal failure. Safe in renal failure. Coming to doxycycline uses. See, doxy is considered a drug of choice. Doxycycline is considered drug of choice in many things, where at least two uses should be remembered at all time. Number 1 is a rickettsial disorder. Rickettsial infection, whether it is typhus fever, we have epidemic typhus, endemic typhus, we have scrub typhus, whether it is Q fever, or whether it is Rocky Mountain spotted fever. So any kind of rickettsial disorder, like any kind of typhus fever, Q fever, Rocky Mountain spotted fever, in all these cases drug of choice will be doxycycline. So that is one important use of doxy which should be remembered at all the time, rickettsial disorders. Second use should be remembered is some of the spirochetal disorders. Spirochetes. Please remember spirochetes. First spirochete comes to our attention, Treponema pallidum. Treponema pallidum, causing syphilis. You all, I hope, know the treatment drug of choice for syphilis is penicillin G. Penicillin G is the treatment without any doubt. But if the patient has a history of penicillin allergy, if the patient presents with history of penicillin allergy, then we cannot give penicillin. Doxycycline is the alternative. So doxycycline has a role in syphilis, a kind of spirochetal disorder. Second, leptospirosis. Leptospira is another spirochete, mild to moderate. Mild to moderate give doxycycline. And if it is severe leptospirosis, penicillin G. Penicillin G is considered the drug of choice for leptospirosis. Third spirochete is Borrelia. Borrelia is another spirochete. Remember Borrelia recurrentis, causing relapsing fever. Recurrentis causing relapsing fever. Again, the choice is doxycycline. And the next species of Borrelia is Borrelia burgdorferi. Borrelia burgdorferi, which causes, I hope you all remember, Lyme's disease. Lyme's disease. Now, treatment of Lyme's disease or Borrelia burgdorferi is same as leptospirosis. Mild to moderate doxy is the drug of choice if severe penicillin or ceftriaxone is used. So in general, DOC is doxycycline for Lyme's disease as well. So these are two uses that I would like everybody to remember in doxycycline. First, rickettsial disorder, very commonly asked, all rickettsial disorder, doxy is the drug of choice. And second is the description of spirochetal infections, treponema pallidum, doxy is the drug of choice for patients allergic to penicillin. Leptospirosis and Lyme's disease, same treatment. Doxy in general is the drug of choice, but if there is a severe disease, then penicillin or ceftriaxone would be preferred. Borrelia recurrentes or relapsing fever, again doxycycline is used. Coming to H. pylori, we will see that tetracycline is more effective or more commonly used than doxy, so that is why the statement is false. Statement number C is false. Question number 11. Which of the following statement about the clinical use of aminoglycoside is false? So again staying with antimicrobial, aminoglycoside and their clinical use, which statement is false? In the uses of aminoglycoside, one statement should be remembered at all the times, and that statement is that aminoglycosides do not act on anaerobic organism. So that is the statement to be remembered all the time at all points regarding aminoglycoside. So in the light of this statement that anaerobes are not affected by aminoglycoside, we will look at the option. We see that option number C, the spectrum of antimicrobial activity includes bacteroides fragilis. This cannot be true because bacteroids are anaerobic organisms. So we have a very simple question, but a very important fact that question number 11, answer is option number C, aminoglycosides. Aminoglycosides. Number one point about aminoglycosides which should be remembered, that they are bactericidal. Bactericidal. Most protein syntheses are bacteriostatic, but aminoglycosides are bactericidal. Second, do not act on anaerobic organisms. Do not act on anaerobes. This includes bacteroids, anaerobes. In specific, we can say bacteroid fragilis. We can also remember acne causing organisms, that is propionobacterium. So please remember, anaerobes are intrinsically resistant to aminoglycosides. Aminoglycosides cannot enter anaerobe, so these organisms will never be treated using aminoglycosides. So that is very important. Third important point in aminoglycosides, they have a concentration dependent killing. Their killing is dependent on concentration, peak concentration with long post antibiotic effect. Concentration dependent killing with a long post antibiotic effect. As a result, they should be given as a single daily dose. A single daily dose would be more effective than multiple divided dose. So this is based on the concentration dependent killing effect, that single daily dose is more effective in aminoglycosides than multiple devices dose. Fourth point in aminoglycoside is that they are having highly polar nature. They are highly polar molecules, so they have water solubility, and that is resulting in renal elimination. Renal elimination. Now if a drug is highly water soluble, it has poor CNS penetration. So that is again a feature of aminoglycosides, that as long as meninges are integrate, as long as meninges are not inflamed, they are not damaged, aminoglycosides cannot enter CNS. Okay? So they are highly polar, water soluble molecules, and they will not penetrate a well formed intact blood-brain barrier. And last common point of aminoglycosides is their side effect of high ototoxic and highly nephrotoxic. So if you remember these points, 5 points about aminoglycosides, you will find that most of the questions about aminoglycosides can be solved. They are bactericidal, not static, very, very important point. No action on anaerobes. So this question which was asked is based on this property. Concentration dependent killing, so their single daily dose is better than dividing the dose in multiple times. Highly polar, so do not act inside CNS until unless meninges are broken, and they are highly auto and nephrotoxic. In their use, 6th point if you want to write, their use, they act on only gram negative, and that is aerobic. That is their spectrum of activity, aerobic gram negative activity. And in their use, aminoglycoside plus cell wall inhibitors like penicillin. If you combine aminoglycoside with cell wall inhibitors like penicillin, this becomes a synergistic combination. So they are frequently combined with penicillins or ceftriaxone. You might have very commonly seen the use of amikacin plus ceftriaxone or ampicillin plus gentamicin. So their combination with cell wall inhibitors is synergistic, and that is how they are used in clinical practice. So all the options are true except option number C. Question number 12, 26-year-old male presents to OPD complaining of hair loss and itching on the scalp. Physical examination reveals a moderate patchy hairy loss with central portion of the scalp, and lesions have ring-like configuration. Ring-like configuration on area involving skin, hair and nail should give a suspicion of tinea. Ring-like, central clearing, peripheral ring spread. With central clearing, so it is very, very diagnostic of fungal infection, dermatophyte infection or tinea in normal language. Which of the following drugs can be used to treat this patient condition? Answer is pretty simple. Antifungal drug terbinafine is considered very, very good for treatment of this condition. So question number 12, correct answer is option number D. Option number D, terbinafine is the answer. We are dealing with tinea capitis. Tinea capitis is what the patient is having. So central clearing and peripheral spread. It is a typical presentation of ringworm or dermatophyte or tinea. Plus the lesions will be itchy or pruritic. So this should raise a suspicion of ringworm or dermatophyte. For tinea, in general tinea, the best drug or the drug of choice we say is itraconazole. But itraconazole is not given in the option. So itraconazole is an orally given drug, and in general for any kind of tinea this is considered best drug. But if itraconazole is not given in the option, then we go for terbinafine. Terbinafine is another drug. Terbinafine is again antifungal, inhibits squalene epoxidase enzyme. Squalene epoxidase inhibitor, terbinafine, antifungal, and terbinafine can be given orally as well as topical. So that is terbinafine for you. In tinea, if itraconazole in general is not given, terbinafine is the second best drug which can be given oral as well as topical. There is a cream as well as tablet. Inhibits squalene epoxidase. To this there is an exception. To the general rule there is an exception. What is that exception? That if there is a tinea of nails, nail fungal infection also known as onychomycosis. So tinea of nail, or also known as onychomycosis, then what is the drug of choice? Here the drug of choice is terbinafine. Terbinafine, which is better than itraconazole. Better than itraconazole. So in any tinea we prefer using itraconazole, oral itraconazole, as the best drug in general. However, if the question is specifically asking tinea of nail, then we look for terbinafine before itraconazole. The question currently is asking tinea capitis. We try to look for itraconazole, that is not given. Second option will be terbinafine. So that is what terbinafine is chosen. Question number 13. Which of the following is true about drugs used in amoebiasis? So amoebiasis caused by entamoeba histolytica. Entamoeba histolytica, let's look at the option. Diloxanide furoate is useful in intestinal and extra-intestinal amoebiasis. This is a false statement. Diloxanide furoate, we will see, is only a cyst killer used only for luminal amoebicide. Imatin is well tolerated orally. This is a very, very wrong statement. Imatin has high, as the name suggests, high emesis and cardiotoxicity. It is a very poorly tolerated drug. Chloroquine is effective only in hepatic amoebiasis. This is a correct statement. So answer is option number C. Option number C, question number 13. Correct answer is option number C. Amoebiasis. Amoebiasis can present in three types. First type is known as asymptomatic carrier. What is the situation? Patient has cyst in intestinal lumen. That is all. He is a cyst passer. He has ingested amoeba which has formed cyst and he is passing cyst. So himself there is no problem, but he is a carrier. What we need for treatment of this, we need a luminal agent. Drugs that will kill cyst of entamoeba histolytica. Luminal agent, will give them orally and they will kill the cyst present in the intestine. The best molecule here is diloxanide furoate. Diloxanide furoate is the best molecule. So therefore you can see the diloxanide furoate will be used only for intestinal carrier state. It is not useful for killing trophozoite in tissues. Diloxanide furoate. Second stage of amoebiasis is amoebic colitis. Amoebic colitis. Now this patient has number one, cyst in GI or intestinal lumen, plus now it has trophozoite in intestinal or colon wall. So these two situations are present in amoebic colitis. Trophozoa has penetrated the intestinal or the colon wall. So there is a cyst in the lumen and there is a trophozoite in intestinal wall. What do we need to treat this condition? We need number one, what we call as tissue agents. Tissue agents. Tissue agents are those that will kill trophozoites in intestinal wall. They are tissue agents used in this condition, and we come to best class of drug, metronidazole type of drugs. Metronidazole, and second is imatin. Imatin. Now please remember, as the name suggests, imatin is having high nausea and vomiting, and it is very highly cardiotoxic, high cardiotoxicity. Imatin, as the name suggests, it will cause emesis when you give it orally, and the more serious problem is high cardiotoxicity. So this drug is very, very poorly tolerated and therefore rarely used. Metronidazole is the best tissue agent, metronidazole or its newer drugs like tinidazole. Once we have killed trophozoites in the intestinal wall, second drug we need to give here is luminal agent, which is best diloxanide to kill cyst from the lumen. Third situation of entamoeba is when it moves from intestinal wall to extra intestinal tissues, and we call it extra intestinal amoebiasis. Mostly that occurs in liver, so we will also call it liver amoebiasis or hepatic amoebiasis. Now what do we need to treat this? We need, number one, tissue agents, but those tissue agents that will kill trophozoite in liver or hepatic tissue. What are the drugs? Metronidazole, and now we have also addition of one more drug, chloroquine. These all are tissue agents, chloroquine. But chloroquine was not mentioned earlier. Why it was not mentioned earlier? Because chloroquine kills trophozoite only in liver, only outside intestine, not in intestinal wall. So it is not used in amoebic colitis, it is used only for extra intestinal amoebiasis. Once you have killed trophozoite, you will give a luminal agent. Luminal agent. So luminal agents are given in all forms of colitis to kill cyst in the intestinal lumen, and diloxanide furovate is the best luminal agent. Tissue agents, metronidazole is the best tissue agent. It kills trophozoite both in intestinal wall and in liver or outside intestine. Imatin is very rarely used because of the reasons described, and chloroquine can kill trophozoite only outside intestine, that is extra intestinal amoebiasis. With this knowledge, most of the questions asked in amoebiasis can be solved. 14th is an image based question. The drug approved for the treatment of above condition. You can see in the first diagram before, there is a submental fat. Below the chin there is fat which makes your chin slightly round, and in after diagram there is loss of that submental fat. It is a fact based question, question number 14. Question number 14, answer would be option number B. Option number B, deoxycholic acid. Deoxycholic acid causes loss of submental fat. That is a one-liner use of deoxycholic, and that is what this fact-based question is trying to ask. So deoxycholic acid will be the answer to question number 14. Question number 15 is a very, very important question. Many times this question has been asked, and so has been this topic of osteoporosis. The question says denosumab, it's a monoclonal antibody against rank ligand, is used for treatment of. The correct answer is osteoporosis, option number B. Question number 15, correct answer is osteoporosis. What is denosumab? We have to understand, and how does it benefit osteoporosis? So we take osteoclast. Osteoclast is a cell present in bone that is causing bone resorption. It causes bone resorption, osteoclast. So let's suppose this is osteoclast. On this osteoclast, there is a nuclear receptor. That receptor is known as receptor for activated nuclear factor kappa, RANK. Rank means, in short, rank. Rank, the R is receptor. So it is a receptor for activated nuclear factor kappa. This is present on osteoclast. Osteoclast. Receptor for nuclear factor kappa. So this is a receptor, rank receptor present on osteoclast. So we know that rank is a receptor present on osteoclast. Okay. So I am denoting this as rank. Rank. Now via blood, this is a blood vessel. This rank will be stimulated by some agonist. Some substance will come via blood. That substance is known as rank ligand or agonist of rank receptor. So rank ligand will come via blood, act on rank receptor, and what happens when rank is stimulated? It causes proliferation of osteoclasts. So proliferation of osteoclast will occur when rank, that is receptor for activated nuclear factor kappa, is stimulated by rank ligand. And you all know that when osteoclast will proliferate or grow and divide and cause more action, there will be increased osteoporosis. More and more of bone resorption. So what we have done, we have developed an antibody known as denosumab. Any drug ending with mab is monoclonal antibody. So it's a monoclonal antibody against what? It is an antibody against rank ligand. So it's a monoclonal antibody that blocks rank ligand. Not the rank receptor but the rank ligand. So again this rank is not stimulated and proliferation of osteoclast decreases. By this there occurs apoptosis in osteoclasts. This is how denosumab benefits patient of osteoporosis by binding to rank ligand and preventing osteoclast mediated bone resorption. So this is denosumab, antibody against rank ligand. Question number 16. The immunosuppressant action of cyclosporin appears to be due to. Very important topic nowadays, immunosuppressant, that is cyclosporin tacrolimus. How do they act? Activation of NK cells, wrong. Blockade of tissue response to inflammatory mediators, that is wrong. Inhibition of gene transcription of interleukins, this is correct. Option number C is correct, and what does it mean? I'll try to explain. Question number 16. Mechanism of cyclosporin, option number C is the correct answer. We are trying to discuss mechanism of action of cyclosporin. The mechanism of action is pretty simple and can be described in one word, and that one word it is an inhibitor of calcineurin. Calcineurin inhibitor. But what exactly is this calcineurin and how does this act? So for us to understand this mechanism in detail, we will have to draw a T lymphocyte. This is a T lymphocyte. This is its nucleus, because we are predominantly going to discuss nuclear mechanism, so I have drawn it much bigger than cytoplasm. This is nucleus. In this, there is chromosome, genes, DNA, whatever you want to call, and one of the genes is present as interleukin 2 gene. So T lymphocytes have interleukin 2 gene. When this gene is stimulated, it will form more of interleukin 2, which will be released, and interleukin 2 will stimulate other lymphocytes. It's a growth factor for other lymphocytes. So what we want for immunity is that this gene, interleukin 2 gene, is transcribed or stimulated or overexpressed. Which substance is going to stimulate or increase the transcription of interleukin 2 gene? Comes the role of NFAT. So nuclear factor of activated T cells is the full form of NFAT. So NFAT is basically a transcription factor, a nuclear factor as the name suggests. And what gene does it transcribe? It's a nuclear factor of interleukin 2 gene. So whenever it is present, it will act on interleukin 2 gene, and this gene would be stimulated, and it will lead to more interleukin 2 production. So then if both things, interleukin 2 gene and NFAT, are present, then this mechanism should always continue, but it does not happen. Why? Because NFAT is present in inactive form. NFAT is bound to a phosphate. It's bound to a phosphate, and this form is inactive. This is an inactive form of NFAT. This will not be able to activate interleukin 2 gene because of this phosphate. Now comes the role of what we call as calcineurin. Calcineurin is a phosphatase. Okay, it is simply a phosphatase. Phosphatase, as the name suggests, will break the phosphate. So calcineurin is a phosphatase. It will inhibit, or it will break, it will hydrolyze the phosphate from NFAT, and NFAT will become active. It will act on interleukin 2 gene, and interleukin 2 will be formed, and interleukin 2 will stimulate other lymphocytes. Now it should be very clear that cyclosporin, or for that matter tacrolimus, cyclosporin or tacrolimus, as I have written, they are simply calcineurin inhibitor. They will block calcineurin. That is the meaning of calcineurin inhibitor. So cyclosporin and tacrolimus, these are two drugs which are calcineurin inhibitor. So if calcineurin is blocked, inhibited, then you can see NFAT cannot become active, and this whole process is stopped. So the ultimate is interleukin 2 gene will not be transcribed. Interleukin 2 will not be formed. This is the mechanism of calcineurin. So again, I will read the options for you. Question number 16, the immunosuppressant action of cyclosporin appears to be due to option number C, inhibition of gene transcription of interleukin, that is interleukin 2. This is the correct answer. How does it happen? By inhibition of calcineurin. Moving on to question number 17, a drug following first order kinetics is being administered by constant IV infusion at a rate of 10 milligram per minute. So 10 milligram per minute is the dose rate given IV. Its steady state plasma concentration is 2 milligram per minute. 2 milligram per minute. If the dose rate is increased to 20, from 10 to 20, what will be the new steady state plasma concentration? Question is very, very simple. Answer will be, we have doubled the dose rate, so steady state plasma concentration will also double. So the answer will be 4 milligram 17th, option number B. Question number 17th, option number B, that is 4 milligram per deciliter will be the correct option. What is the principle behind? Dose is given by clearance multiplied by steady state or target plasma concentration. This is a very simple formula, that plasma concentration is directly a function of dose. That is what we mean. So if we remove clearance, it means dose is directly proportional to plasma concentration. That is what we should know. If we, by this logic, if you make the dose 2x, double the dose, then plasma concentration will also double. So at 10 milligram, we look at the question, 10 milligram per minute. 10 milligram per minute initially, the plasma concentration is 2 milligram per liter. You increase this 10 to 20 milligram per minute, dose you have doubled, so the plasma concentration will also double. That is very simple. So there are two things as a concept. Number one, steady state plasma concentration. That means the level in blood at steady state. This is directly proportional to dose. Please remember, if you increase the dose, the level at plasma concentration steady state will increase or double or triple in as per dose. If you increase the dose 10 times, the plasma concentration will increase 10 times. Second, time taken to reach steady state plasma concentration. How much time it takes to reach steady state plasma concentration is always fixed. It is not dependent on dose, and that is always 4 to 5 T halves. So there are two things that should be remembered. What is the plasma concentration at steady state? That is directly a function of dose. You increase the dose, the level in blood will increase, steady state level will increase. But in how much time the steady state will come is always fixed, and that is 4 to 5 T half. So no matter what you do, if you increase or decrease the dose, as long as dose is constant, the time taken to reach steady state is always fixed. So if we, for our better understanding, if we see this in a graph, okay, so what we are drawing, this is plasma concentration and this is time. Okay, the black line will represent, let's say, x milligram per minute dose. Dose is given as x, and the pink line will represent 2x, double of the initial 2x milligram per minute. Okay, this is plasma concentration, that is steady state level, and this is the time. When you give x, this is the kind of graph. So let's say this is the level of steady state. So we see that time taken to reach steady state is this, and level at steady state is this. Level at steady state plasma concentration is this, and time taken is this. Okay, so when you give x milligram, steady state comes in this much time, and the concentration at steady state is this. Now you are giving double the dose. So if I show you, we'll remove this. So now we are giving double the dose. So what will happen? This is the kind of graph that we will see, that concentration at steady state will double, but the time taken to reach steady state will remain the same. So this is what we mean by the level at steady state. You increase the dose, level at steady state will increase, but the time taken to reach steady state will remain the same, no matter what the dosing is. This is true for any drug following first order equation. Most of the drugs follow first order equation, so that goes beyond saying. Steady state plasma concentration is dependent on dose, but time to reach steady state is always fixed. That is dependent on T half, and this will always be 4 to 5 T halves. 4 to 5 T half, time taken to reach steady state, and this is the steady state. So this is how you can better understand by using this graph. Question number 18. Increased force of cardiac contraction, which of the following statement is most correct? So we are given three graphs. You can see we have response on y-axis and we have the concentration on x-axis, A, B and C. So this is a dose response curve. Three graphs are shown. Dose response curve. Which is the most correct? So let me draw this on our sheet. Question number 18. Correct answer we will see later, but let's first draw this on our sheet. So this is A, B and C. Drug A, drug C and drug B. This kind of graph is given. This is response and this is dose. So dose response curve has been, I hope I have drawn it correctly. Yes, that is correct. This kind of response is seen. Now you see there are two things. One is potency and the other one is efficacy. That we can measure or we can comment using this graph, potency and efficacy. Potency is the amount of drug required to produce a fixed response. Amount required, how much dose is required to produce a fixed response, whether 10 milligram or 20 or 100, that is called potency. Potency is the dose required to produce a fixed response. Efficacy is the maximum response produced by the drug. Maximum response produced by the drug is known as efficacy. What is more important is potency is given by position on the curve. On the graph, dose response curve, leftward means more potent. If the graph is towards left, the drug is more potent. Efficacy is given by height of curve. Height of the curve gives you efficacy, and higher the graph, more is the efficacy. So dose response curve can be used to comment on two parameters, potency as well as efficacy. What is potency? Potency is the amount or the dose of a drug required to produce a fixed response. Whether 10 milligram of a drug is needed or 20 or 100 or 1000, how much dose is needed. Efficacy is the maximum response produced at any dose is efficacy. Potency is given by position of the curve, whether the curve is on the left side or the right side. If it is on leftward, the drug is more potent than those which are present on right. While efficacy is given by height of the curve, higher the curve, more is the efficacy. So in the light of these information, we look at these three curves. It is very clear to us that the maximum potent drug is A, because the curve is on the leftmost side, so the maximum potency is with drug A. The least potent drug will be drug B, because the curve is on the extreme right out of the three drugs given. So this is clear, leftwards versus rightward. Coming to efficacy, most efficacious, that means the highest curve is very clear, graph number B. Graph number B or drug number B is the most efficacious because it is the highest amongst the three graphs. So then we know that drug B is most efficacious, but drug A is most potent. So we can look at the option. Drug A, option number A, drug A is most effective. This is wrong. Very clearly drug B is most effective. Drug C is most potent. That is incorrect. Drug C is less potent than drug A, but more potent than drug B. Drug B, option number C. Option number C says that drug B is less potent but more efficacious than drug C. So as we have seen, the graph of drug B is highest. So it is most efficacious, that is more than drug C. But it is towards the right of drug C, so it is less potent. So this option number C. Option number C is the correct answer to this question. So if you know potency and efficacy, then all such drug response curve questions can be solved. Remember, potency is P, position, efficacy is height. Moving on to question number 19, which is the most dangerous effect of belladonna in very young children. This is again a fact-based question. Answer is hyperthermia. Belladonna or atropine or anticholinergics. So question number 19. Question number 19, correct option will be option number D. Option number D is the correct answer. Belladonna or atropine or anticholinergic side effects. How to remember? And with respect to children, which is most dangerous. So we can remember this by a simple statement that atropine makes you. Atropine makes you. Number one, the first effect is on secretions. So dry as a bone. Secretions dry up and that results in dry mouth, dry skin and dry eyes. Dryness, secretions drying up, glands reducing in activity is the earliest belladonna poisoning or atropine poisoning symptoms. Now see, skin, sweating has reduced and that is why skin has become dry. So when sweating reduces, skin becomes dry, body temperature will increase. So this will result in hyperthermia. Hyperthermia known as hot as a hare. It is not our human hair, it is the cousin of rabbit, hair. So hot as a hare, hyperthermia, and this is the most dangerous in children. Children are highly susceptible to developing hyperthermia and therefore even 2 milligram, as low as 2 milligram atropine have caused death in children due to hyperthermia. So please remember, hyperthermia, high risk in children. That is the answer to this question, but we'll continue and see what are the other side effects seen. Hot as a air or hyperthermia, that is the another problem with atropine. Now when hyperthermia occurs, body temperature goes up, but sweating cannot occur because sweating has reduced anticholinergic side effect. How will body lose this heat? This will occur as peripheral flushing. Peripheral vasodilation will come and blood will be lost or heat will be lost from blood to environment. So this will make the body red and hence the term red as a beet. So peripheral flushing resulting in redness of face and limbs. is the third problem in atropine poisoning or atropine overdose. Body turns red as a beet. Then fourth thing which happens is cycloplegia in eye, cycloplegia which results in blurring of vision. Blurring of vision, cycloplegia due to paralysis of ciliary muscles, and patient will be called as blind as a bat. Blind as a bat because he cannot open his eyes because there is too much mydriasis. So you'll recall, in eye there are two effects, cycloplegia is one and mydriasis. Due to mydriasis, he cannot open his eyes because there is photophobia. Lot of light entering the eye resulting in photophobia. So patient cannot open his eyes, even if he opens he cannot see clearly because of cycloplegia, so blind as a bat. And finally at high dose, fifth feature will arise, which is mad as a hatter. Mad as a hatter, that is delirium, is a feature seen in atropine or belladonna poisoning at high dose. So these are the 5 features which are seen in atropine or belladonna poisoning. Dryness is the earliest. You can write it is the earliest, resulting in hyperthermia, which the question is asking most dangerous in children. Children are highly susceptible to develop hyperthermia. So try to avoid anticholinergics or especially atropine in children at all times. Peripheral flushing resulting in redness, cycloplegia with mydriasis resulting in blurring of vision, blind as a bat, and delirium at high dose, mad as a hatter. So these are the atropinergic side effect or belladonna side effect. And in young children, hyperthermia is the one which is most dangerous. Moving on to question number 20. Which of the following drug acts as a combined alpha and beta adrenergic receptor agonist? Combined action on alpha and beta receptor. Let's look at the option one by one. Dobutamine. Question number 20. Answer will come in the end. Let's look at the options given. Dobutamine. Dobutamine, for all practical purposes, is a pure beta 1 agonist. Pure beta 1 agonist. So it does not act on alpha. So this is not the correct answer. Second is given as phenylephrine. PE, phenylephrine. It is a pure alpha 1 agonist. Acts only on alpha 1, on no other receptor. So again phenylephrine is not the answer. Option number C is phenyldopam. Phenyldopam. Phenyldopam acts only on D1 receptor, D1 agonist, and it is used as a vasodilator. Vasodilator, phenyldopam, vasodilator acting on D1 agonist. So these three obviously are not the answer. So what is the answer? Answer will be option number D, that is noradrenaline. Noradrenaline. Noradrenaline acts on alpha 1 plus alpha 2 plus beta 1 receptor. These are the three receptors on which noradrenaline acts. So this is the answer to question number 20. Option number D, noradrenaline. It acts on alpha 1, alpha 2 and beta 1. Now this is the answer, but we should also look at some of the other possible options or other related molecules. So adrenaline should also be considered. Adrenaline acts on alpha 1 plus alpha 2, both alpha, plus it also acts on beta 1 plus beta 2. So you can say A for all. Adrenaline acts on all adrenergic receptor, both alpha and both beta. A for all. This also makes us clear the difference in adrenaline and noradrenaline. NA is not all. So you can see it has beta 2 action which is missing. beta 2 action, or I would say beta 2 action is missing from noradrenaline. It does not act on beta 2 while adrenaline acts on beta 2. And lastly, one should also consider dopamine. Dopamine again has a dose dependent action. The action is dependent on dose. So at low dose, it is the D1 agonist, plus means agonist. At moderate dose, it will act on D1 and beta 1, D1 and beta 1, and at high dose, it will act on D1, beta 1 and alpha 1. So it has a dose dependent action. Low dose only D1, known as the renal dose. Moderate dose stimulates beta 1 also present on heart, so cardiac dose, and high dose acts on alpha 1 also in addition to D1 and beta 1, known as pressor dose. So these are some molecules which are commonly asked, their mechanism of action or receptor action also commonly asked. So please remember, dobutamine only beta 1, phenylephrine pure alpha 1, phenyldopam pure beta D1, noradrenaline, adrenaline, dopamine, they have action on both alpha and beta, but their actions again are different from each other. So this is about question number 20. Answer will be option number D, noradrenaline, as I have explained. Question number 21. H1 antihistaminics afford benefit in a number of conditions. All of the following conditions are benefited by antagonism of histamine except dermographism, that is pruritus mostly, insect bite, common cold, seasonal hay fever. Answer will be C, common cold. Question number 21, answer is option number C. So, use of antihistaminics, H1 blockers. Number one use is based on antihistaminic activity, that is H1 blocker, and number two use is based on anticholinergic activity. So remember, first generation antihistaminics have prominent anticholinergic activity as well. So this is present in first generation antihistaminics, anticholinergic activity. So based on these two properties, they have two kinds of uses. Based on antihistamic property, any allergic condition. Allergic conditions like hay fever, serum sickness, pruritus, all these are benefited by antihistaminic property, allergic conditions. Based on anticholinergic activity, number one, common cold, which is considered to be a viral disorder, not allergic condition. So, reduction in secretions. Due to anticholinergic property, reduction in secretion reduces rhinorrhea. That is believed to be mechanism in common cold. Secondly, they are used in Parkinsonism. Again, because of anticholinergic activity, and again used in motion sickness. So number one, number two, and number three. These are three uses of antihistaminics which are based on anticholinergic property. And remember, anticholinergic property is present only in first generation antihistaminics. So these are the first generation antihistaminics which can be used for common cold, Parkinsonism and motion sickness, while antihistaminic activity is responsible for benefit in allergic conditions like hay fever, serum sickness, pruritus, allergic rhinitis or conjunctivitis. All these actions are based on antihistaminic properties. Question number 22, it's very simple. Many times asked question. Two antihistaminics, terfenadine and estimazole, were withdrawn from the market following the occurrence of arrhythmias when they were present in high levels in blood. Their effects are explained by the fact. So why were terfenadine and estimazole withdrawn? Because they were causing QT prolongation resulting in arrhythmia, and the reason was blockade of cardiac potassium channel. Let's look at the option. Use of these drugs by addicts, this is not the answer. Genetic predisposition to metabolize succinylcholine, this is nothing to do with antihistaminic. Concurrent treatment with phenobarbital is again nothing to do with these drugs. Treatment of these patients with erythromycin, a macrolide antibiotic. This is the correct answer, option number D. Question number 22. Question number 22, option number D is the answer. So what is happening? Estimazole and another drug is terfenadine. These are two antihistaminics, H1 blocker antihistaminics. In addition to blocking H1 antihistaminic, they also block cardiac potassium channels. Cardiac potassium channels were also blocked by these drugs in addition to blocking H1 receptor. Blockade of cardiac potassium channel results in increased QT interval, and this results in an arrhythmia, ventricular arrhythmia known as Torsades de Pointes. This was a property seen with these drugs, that blockade of cardiac potassium channel was resulting in arrhythmia due to prolongation of QT interval. Now, further if we see, these drugs are metabolized in liver. Like most other drugs, they are metabolized in liver by CYP3A4. This cytochrome was involved in their metabolism. If you inhibit this cytochrome by CYP3A4 inhibitors like erythromycin, ketoconazole or cimetidine. These are three prominent drugs which are inhibitors of CYP3A4 in liver. So by inhibiting CYP3A4, they will cause increased level of estimazole or terfenadine and therefore increased risk of cardiac arrhythmia. So that was something that was not acceptable. For an antihistaminic drug to cause cardiac arrhythmia, which sometimes can be fatal, was very dangerous, and therefore these two drugs, terfenadine, estimazole, were withdrawn from the market. Terfenadine, estimazole have been withdrawn because of risk of cardiac arrhythmia, especially increased if given along with CYP3A4 inhibitor. Just to conclude, fexofenadine. Fexofenadine is an active metabolite. It is obtained from terfenadine. So it is derived from terfenadine, but this one lacks or does not potassium channel blocking action. So fexofenadine is commonly used. It is a product of terfenadine without potassium channel blocking action, without risk of arrhythmia. So fexofenadine you will find by the trade name Allegra. Tablet Allegra, very commonly available. Fexofenadine, product of terfenadine without cardiac potassium channel blocking or arrhythmia causing side effect. Sorry. Moving on to question number 23. Which of the following drugs is beneficial in a refractory congestive heart failure by increasing cardiac contractility and decreasing preload and afterload? Answer to this question would be option number C, ambrinon. Ambrinon. So we have two properties needed: increasing cardiac contractility and decreasing preload and afterload. Correct answer is option number C. Question number 23, answer is option number C. And how is that happening? So we have in the question benefit in CHF. Drug is benefiting CHF by causing increased in cardiac contraction. And also causing reduction in preload and afterload on heart. This is what is mentioned in the question, that drug is increasing cardiac contractility, which can be defined as positive ionotropic action, positive ionotropic, and preload, that means decrease in venous return is preload, that is decreasing, and afterload is decrease in peripheral vasoconstriction. Both these things are decreasing, that means veins are dilating, that's why venous return is decreasing, and arteries or arterioles are dilating, that means afterload is decreasing. So that means the drug is a vasodilator. So we have two actions which are produced by the drug in the question, positive ionotrope and vasodilation. If we combine these two, we get a term which is ionodilate. So drug in question is ionodilator, and that is ambrinon, or its newer derivative milrinon. That is the answer to this particular question. And how do they do? What is the mechanism of action of these drugs? I hope you recall that they inhibit the enzyme phosphodiesterase type 3. By inhibiting the enzyme phosphodiesterase type 3, they cause ionotropic plus vasodilator action. Ambrinon, or its newer derivative milrinon, ionodilator. That is what the question is saying. Increase in cardiac contraction, ionotropic, and decrease in preload or afterload, that is vasodilation. Ionodilator is what is being asked in the question. So 23, option number C is the correct answer. 24, this is an image based question. What does it show? It gives a history of gardener who is also a patient of HIV. So there is a patient who is a gardener working with plants, so there is exposure of various kind of microbes. We should keep that in mind, plus the person is immunocompromised. He is developing ulcerative papules with mild pain as shown in the diagram. So we can see along his hand, ulcerative papules have developed. After a few days, he has developed headache plus seizure. So now there is CNS involvement. The drug that should be started in this patient is, answer would be amphotericin B. Question number 24. The answer is option number C, amphotericin B. How to approach this question? Very good question. There is a patient who is given a history, occupational history of gardener, plus immunocompromised because of the HIV positive status. Now these two histories, exposure to various plants plus immunocompromise, should raise a suspicion of a fungal disorder known as sporotrichosis. Sporotrichosis. Now sporotrichosis generally manifests as, the symptoms of sporotrichosis include ulcerative papules. Ulcerative papules, and for this treatment, excuse me, we can give the patient itraconazole. Itraconazole if the condition is present only at the level of ulcerative papules. Further, the symptoms may have CNS involvement, and CNS involvement may manifest as seizure. Now, if both the conditions are present, then it denotes a more widespread or life-threatening nature of the disease. As a rule, please remember, if a fungal infection becomes life-threatening, most of the time the drug of choice will be amphotericin B, and that is what is the answer to this particular question. So amphotericin B can be used in most of the life-threatening fungal infection, like this case If only ulcerative papules were present, itraconazole would have been a better option because this is oral drug and effective for dimorphic fungi. But since there is CNS involvement with headache and seizure, this infection is systemic, widespread, perhaps life-threatening. So a more stronger, broad spectrum, more effective antifungal in the form of amphotericin B, which is given intravenously, has to be used, and that is what is the answer to this question. Question number 25, which is not associated with thiazide diuretic. So we are given some metabolic electrolyte problems and which is not associated with thiazide diuretics. Hypercalciuria, option number A, this is the correct answer. This is the correct answer, option number A, 25. So let me tell you the metabolic or the electrolyte problems which are seen with both thiazides and furosemides. What are common side effects? So if you are asked, you can clearly answer such kind of questions. Number 1, because they are diuretics, they will cause volume loss, so hypovolemia. Hypovolemia, loss of plasma volume. This is more with furosemides and less with thiazides. So more hypovolemia is caused by furosemides. Second, please remember hyponatremia. Loss of sodium, hyponatremia along with urine occurs with both, but this is more common with thiazide as compared to furosemide. Very, very important point which most students do not recognize. More sodium is lost in urine secreted or given out after thiazide as compared to furosemide. More urine is produced by furosemide, but that urine has less of sodium. Thiazides as compared to furosemide produce less urine, but that urine has more sodium in it. So hyponatremia is seen with both, but it is more severe, more common with thiazides. Please remember that. Third, hypokalemia. Hypokalemia is the most common side effect in chronic use with diuretics. Hypokalemia occurs with both and mostly with the same intensity, but this is the most common chronic side effect of thiazide as well as furosemide. Fourth, metabolic alkalosis. Metabolic alkalosis occurs with both. And fifth, what will happen to chloride? Will it increase or will it decrease? How to remember? Metabolic alkalosis, this means that pH is going up greater than 7. Now please remember, there is an indirect relation, inverse relation between pH and chloride. So if pH is going up, chloride will go down. So hypochloremia. Chloride will go down. This will also happen with both and probably with the same intensity. These 5 losses will occur with both of them. Sixth, some hyper. What are hyper? Hyperglycemia, hyperlipidemia, and hyperuricemia. These 3 hyper will occur with both, but they are again more common with thiazide as compared to furosemides. So hyperglycemia, hyperlipidemia, hyperuricemia will occur with both diuretics and more common with thiazide as compared to furosemides. So these 6 problems will occur with both classes of diuretics, and that is what you should remember as the common side effects of furosemides and thiazides. In these, emphasis should be made on remembering hyponatremia, more common with thiazides, and the hypers, which are again more common with thiazides. Now coming to side effects which are different. Now since they are different, they are the ones which are more commonly asked. So thiazides versus furosemide. What is to be remembered first of all is the effect on calcium. Effect on calcium, thiazides cause hypercalcemia. Hypercalcemia. They increase calcium reabsorption. from urine. They will increase calcium reabsorption from urine, resulting in hypercalcemia, and because of this action they are considered drug of choice for treatment of hypercalciuria. They treat hypercalciuria, they are considered drug of choice for hypercalciuria because they increase calcium reabsorption from urine, resulting in side effect of hypercalcemia. This is true with thiazides. While furosemides have an opposite effect on calcium, they cause hypocalcemia. They decrease calcium. Hypocalcemia, they increase calcium loss in urine. They cause more calcium to go out in urine, that is why resulting in hypocalcemia, and this property makes them drug of choice for treatment of hypercalcemia of malignancy. They are used in treatment of hypercalcemia of malignancy. So this is the most important point that is frequently asked in various forms in various competitive exams. Thiazides and furosemides. Opposite effect on serum calcium. Thiazides cause hypercalcemia, and this is because they increase reabsorption of calcium from urine, resulting in treatment of hypercalciuria. Furosemides have opposite effect on calcium. They increase calcium loss in urine, resulting in their use in hypercalcemia of pregnancy. This is the question, this is the point that the question is asking. Question number 25, that which side effect is not seen with thiazide diuretic? The clear-cut answer is regarding calcium. Hypercalciuria they treat, they do not cause. So option number A is the correct answer. I think question number 26 we have already discussed. A 50-year-old man has a history of frequent episodes of renal colic with high calcium renal stones. There is a history of calcium renal stones. The most useful diuretic in the treatment of recurrent calcium stone, answer is hydrochlorothiazide, or option number 26. As we have discussed earlier, if patient is having hypercalciuria, if somebody is suffering from hypercalciuria, more calcium in urine, it will cause calcium precipitation in urine. Because there is too much calcium in urine, it will precipitate, and this will cause calcium renal stones, also known as calcium nephrolithiasis. This is the question, this is the complaint that the patient the question is presenting with. He is hypercalciuria resulting in calcium renal stone. How do we treat such a patient? The drug of choice for treatment is thiazide group of drugs. Thiazides will be called drug of choice, and what will they do? Thiazides will increase calcium reabsorption from urine. As stated earlier, they will increase calcium reabsorption resulting in resolution of renal stones. So that is why they are drug of choice for, you can call calcium nephrolithiasis or idiopathic hypercalciuria. And please remember again, this will result in a side effect of hypercalcemia. Blood calcium will rise. So if patient has excessive calcium stone, give him thiazide group of drugs. That is the answer to question number 26. Question number 26, option is, correct answer is option number C. Option number C. Moving to 27, long-term steroid therapy can lead to suppression of hypothalamic pituitary adrenal axis. That is very correct, true statement. It can be overcome by using alternate day therapy with corticosteroid. This is one approach to reduce their long-term side effect. Give the steroids on alternate day. Which of the following steroids are unsuitable for alternate day therapy for such purpose? So basically, if the drug is very long acting, then even the alternate day approach would not work. So we are looking for a long term or long acting corticosteroid. Answer is beta-methasone. Question number 27. Beta-methasone given as option number C. Beta-methasone is the correct answer, and why this is the correct answer. So alternate day steroid therapy, it avoids high concentration of steroids in plasma for long time. That is the principle. You will give it alternate day, so their duration of action in plasma will be less, their level in plasma will not remain high for very long. So we need short T-half drugs, shorter acting drugs, they will be useful. If the drug is longer acting, even the alternate day therapy will not be effective because the drug will remain high in plasma for long duration. So if we look at classification of steroid, we find that there are certain short T-half, moderate T-half and long acting or long T-half molecules. Short T-half, cortisol, also known as hydrocortisone, shorter acting. Moderate में we can add prednisolone or its methyl derivative methyl prednisolone. And in the longer T-half, longer acting, which are not suitable for alternative therapy, we have two, dexamethasone and beta-methasone. So these two are long acting and therefore not suitable for alternate day therapy. Dexamethasone and beta-methasone. These are the longer acting, although highly potent, but longer acting and therefore not suitable even if you give alternate day, they will result in chronic side effect. So these are two which are highly potent steroids but still not suitable for long alternate day therapy because of longer duration of action, dexamethasone and beta-methasone. So option number C is the correct answer of question number 27. Moving to question number 28. Which of the following hypnotic drug facilitates the inhibitory action of GABA but lacks anticonvulsant or muscle relaxant property and has minimal effect on sleep architecture? So we have a couple of information in the question. The drug is acting via GABAergic system, but it should not have anti-epileptic or muscle relaxant property and minimal disturbance of the sleep architecture. We look at the option buspirone. Buspirone is an I hope you are recalling, buspirone is an anti-anxiety drug, not a sedative hypnotic, and it does not act via GABA. Diazepam acts via GABA, it's a benzodiazepine, but it has anticonvulsant property. Please remember, it is a drug of choice for febrile seizure. It is one of the first drug in status epilepticus. Phenobarbital, barbiturate, I hope everybody knows, acting via GABA, but possesses significant anticonvulsant activity. Zaleplon is a W or the non-benzodiazepine hypnotic, and that is the answer to this question. So question number 28. Option number D, Zaleplon is the correct answer. So GABA agonists, that is which GABA receptor? GABA A. Remember GABA A, not GABA B. GABA A receptor agonists. The first class of drug is barbiturates. Barbiturates act as GABA facilitator initially, and at high dose they become GABA mimetic. At high dose. So they are acting on GABA A receptor initially as facilitator, later as mimetic, and they have anti-epileptic actions, and they cause significant distortion of sleep pattern or sleep architecture. So they cannot be answered to this question because they have these two properties, which should not be if they were to be the answer. Moving on to benzodiazepines like diazepam, they are again GABA facilitator. They remain GABA facilitator, never become mimetic, so they act via GABA system. They also have significant anti-epileptic action. Anti-epileptic action is present. Please remember, they are drug of choice for status epilepticus. Benzodiazepines like lorazepam, diazepam, the first drug, and they cause minimal, but still they cause minimal distortion of sleep, less than benzodiazepines, but still they cause. So again, they are not the answer to this particular question. We come to third class of drugs which are acting on GABA, Z drugs. Z drugs, or also known as non-benzodiazepines hypnotics. Non-benzodiazepine hypnotic, what is their mechanism? This is very important to be remembered. They act again on GABA A receptor, number one. They act on GABA A receptor, so they are acting via GABA receptor, GABA type A, like benzodiazepine, like barbiturate. Which site on GABA receptor do they act? They act at benzodiazepine site, the same site as benzodiazepine, that is at the interface of alpha and gamma unit. They bind at the same site where benzodiazepines bind, that is at the junction of alpha and gamma, but they bind only to that GABA A receptor which has alpha type 1 subunit. Alpha type 1. Not all alpha, alpha again is of 4 to 5 types. Only that GABA receptor which has alpha 1 subunit will be the site or the receptor targeted by Z drugs or Zeliplon. Now these drugs have no anti-epileptic action, no abuse liability, no sleep pattern distortion, no tolerance or dependence, that is what is claimed. However, in practical life there is some, and they have minimal drug interactions. So these are the properties of Z drugs or Zeliplon. Z drugs are like zolpidem, Zeliplon, zopiclone. So they have GABAergic action, but without anti-epileptic action. Without anti-epileptic, they are not used to treat epilepsy, and they have other advantages also, like minimal disturbance of sleep, minimal drug interaction, and no abuse liability. So that is why they have become preferred drugs for treatment of insomnia nowadays. Moving ahead, staying with benzodiazepines, question number 29. A very potent and short-acting benzodiazepine was given to a patient for purpose of causing hypnosis. But the drug caused psychiatric disturbances in him. Which of the following can be hypnotic used? This is a fact-based question. Flurazepam, nitrazepam, they are very long-acting. Triazolam is the one which is very short-acting and has problem of causing psychiatric side effects. So question number 29, option number D, triazolam. Triazolam, this is the shortest and the quickest acting benzodiazepine, triazolam, and this has side effect of causing high, number one, high abuse potential. So that is one problem, and then it can lead to certain psychotic behavior or psychosis. So triazolam is the one that question is asking. It's a fact-based question. Shortest acting benzodiazepines. When you take it, it produces immediate action that results in high kick or abuse potential, and also it can cause psychotic reactions. Question number 30 is an image-based question. What you see in the image is a child with developing bluish tongue and slightly bluish discoloration of hands. What drug is used? This is again a fact-based question. Mitozentron. Question number 30. Option number C, that is mitozentron. Mitozentron is the answer. Mitozentron is an anti-tumor antibiotic. So this is an anti-cancer drug, anti-tumor, belonging to antibiotic class, obtained from microbes. Microzentron is used, number one, in prostatic cancer, prostate, and secondly, its non-cancerous use is of extreme importance. It is used in multiple sclerosis. So in cancer it is useful for treatment of prostate cancer, and in non-cancerous condition it is used for treatment of multiple sclerosis. Now certain side effects of these drugs are of importance. Number one, most serious is cardiomyopathy. This is the most serious side effect of this particular drug, because this is also an anthracycline related to doxycycline, so it can also cause cardiomyopathy. It is cardiotoxic. And second is, it can cause extravasation of fluid. So it can cause extravasation of fluid, and that can result in bluish discoloration. So that is why this is the answer to this particular question. Bluish discoloration due to extravasation of fluid. Question number 30, option number C, mitozentron, is the answer to this question.